Welcome to the Ticktective podcast, a program of the Bay Area Lyme Foundation, where our mission is to make Lyme disease easy to diagnose and simple to cure. I'm your host, Dana Parrish, and I'm the co-author of the book Chronic, and I sit on the advisory board of Bay Area Lyme Foundation. This program offers insightful interviews with scientists, clinicians, patients, and other interesting people. We're a nonprofit based in Silicon Valley, and thanks to a generous grant that covers 100% of our overhead, all of your donations go directly to our research and prevention programs. For more information about Lyme disease, please visit us at bayarealyme.org.
Hi there. I am so excited today because I'm here with Dr. Todd Maderis. Thank you so much for being here today. I'm thrilled to talk to you. So let me tell you a little about Dr. Maderis. He's the founder and medical director of Marin Natural Medicine Clinic in San Francisco Bay Area. He specializes in treating tick-borne infections, chronic viral infections, mold illness, and other conditions associated with complex chronic illness, such as mast cell activation disorder and ME/CFS. His approach to treating chronic illness is to identify all underlying causes of symptoms to provide a clear direction for treatment. With over a decade of experience treating Lyme disease and complex chronic illness, he knows that every patient is unique and requires individualized treatment therapy. So welcome, welcome, welcome. It's great to see you.
Thank you for having me. It's great to be here.
How'd you get into this mess?
Oh gosh, that's always a great question. And you start going down the rabbit hole and sometimes you wonder, but I wouldn't change a thing. You know, I started out treating people with common complaints. My first 5 years of practice, digestive issues, fatigue issues, thyroid issues, etc. I'm a naturopathic doctor, so we tend to see people that come with common complaints that maybe they're not getting answers in conventional medicine. And one visit, I had a patient that brought in a Lyme result, and someone had ordered the test. It was an IGeneX test, but back then the results were pretty hard to interpret. And
what is IGeneX for people that are new to
here? Sure. IGeneX is a Lyme testing specialty laboratory that's here in the San Francisco Bay Area, and they have been doing testing for tick-borne infections for over 30 years. Really the in my opinion, the gold standard for testing for tick-borne infections. Anyhow, the results at the time were sort of hard to interpret. I didn't know, couldn't make heads or tails of them. And around the same time, a colleague had told me about a Lyme conference, and the next thing you know, I was on a flight to a conference. And at the time, it was a very small conference. There was very few of us in the audience and a lot of great speakers. As we were talking before we started the recording, once you learn something, it's hard to unlearn it, or it's a little negligent to pretend that it's not there. So that really changed the course of my practice. And then of course you really learn from your patients. People come in with different complaints, or maybe what you're addressing is not resolving their symptoms. And so you keep searching. And I think medicine, you have to be curious in medicine. It's important to stay humble as well, because you get surprised and you learn things. My practice has just evolved over the years, and it's I wouldn't change a thing what I'm doing now. I really enjoy it.
Yeah. Well, it's been nice to have a relationship with you over these last couple of years, and know that I could talk to you about toxic mold, about chronic Lyme, about long COVID, and about all the other immune assaults that we face just living in the world today, and being able to send you patients with all these different complex issues that you've been able to unravel. And one of the things I'm really excited to talk to you about is toxic mold. I think it is hugely underappreciated all over the world, and it's a huge problem all over the world. And I think doctors don't really know to look for it. So I'm kind of curious what your experience is and how you came to recognize it as such an important factor in the chronic illness world.
Yeah. It was one of those things that I never thought I would, I sometimes joke, if you asked me 10 years ago, I would be treating mold illness. At the time I didn't know what it was, but about 10 years ago, I was at a large international Lyme conference, and I remember looking at the lineup of speakers for the weekend, and typically all the talks are related to Lyme or co-infections, and there was one speaker in the lineup that was talking about mold illness, and an infectious disease doctor named Joe Brewer from Oklahoma. And at first I thought, he's in the wrong place. This isn't the wrong conference. And then after hearing his talk, it turns out that toxic mold or mold illness can present very much like Lyme, and
like
mold.
Rattle off some of the symptoms, just because I think, again,
sure,
people that have no idea what we're talking about.
Right. Yeah. And I think what's important is to make the distinction between, in conventional medicine, we talk about mold allergy, right? Occasionally I'll see someone that'll say, oh, my primary tested me for mold, and, but it was normal. It was a LabCorp test, and they tested but those are mold allergies. So that's an antibody test to detect a mold allergy. And we have mold allergies. We also have mold illness, and then people can have, some more serious conditions like pulmonary aspergillosis. And, so what we're referring to is an elevation of mycotoxins, which are a secondary metabolite of mold. So people get exposed to water damaged buildings. That's the term that's used. And we inhale mold spores, and those mold spores can colonize in humans, typically in the sinus cavity or the GI tract, and they'll continue to make mycotoxins. These molds will produce the mycotoxins well after someone has left that moldy environment. And so it's similar to Lyme, right? You could have a tick bite 5, 10, 15 years before you develop symptoms, and then something happens, almost that perfect storm. And sometimes mold is part of that perfect storm, because mold is very immunosuppressive. So when I talk about mold illness, the symptoms can range from fatigue and brain fog, headaches, anxiety, depression, to respiratory symptoms, to arthralgias, aches and pains. There's a whole myriad of symptoms that can come, because essentially the toxin is triggering an immune cytokine response. So there isn't just, not an allergy type of symptom or a respiratory only symptom. It's a systemic, multi-symptom illness similar to mold.
I think people don't appreciate too that if they're living in a moldy environment and there are mycotoxins they're airborne, they're microscopic, and you're inhaling them.
That's
and
right.
You're getting neurologic symptoms. Again, like I agree, like most of the time, it's sort of like the Lyme thing, right? It's just arthritis. It's like a swollen body. No, actually, it's totally not. It also goes into your brain, and you also get neurologic symptoms. And it was deeply disturbing to me to find out, as much as I have learned in the last couple of years about toxic mold. I didn't know it can be used as a bioweapon. These are really, really, as Dr. Mal had said to me, these are true poisons. Mm-hmm. And I think they're really, really appreciated. So if you suspect a patient has been exposed, and one of the problems that's affecting them is toxic mold, what do you do?
Well, it always starts with a history. Rarely do people walk in the door and know that they have mold exposure. Occasionally someone will suspect it. And of course, my practice is specialized, and so people may seek me out for that diagnosis. But it's not, people typically aren't aware of it. Mold does not like light. It doesn't tend to grow out where we can see it. What is factored into a rise in mold illness maybe in the last 5 decades? Probably construction has played a role. We now have cavities in every wall, which are a perfect source or location for mold growth. So inside of walls, where it's dark and damp, mold likes to grow. Again, it doesn't typically grow out where we can see it. I once had a Lyme patient at the time, who had moved to Brooklyn, and she hung a painting on the wall when she moved into her apartment.
Oh
And
no.
yeah, you know where this is going. And within 3 months, she got really sick, and she had to move back home and to San Francisco to live with her parents. When she left the apartment, she took the painting off the wall, and mold had grown in the shape of the painting. And so the mold was, the mold was already there. All she did, the moisture inside of the wall was there, that she covered, blocked the light with the painting. Mold had grown. And so mold tends to lurk in places. It doesn't have to be obvious, like a roof leak and you see a water stain on the ceiling. Toilets overflow, bathtubs overflow, dishwashers leak, wash machines, etc. Crawl spaces. I'm in Marin County, just north of San Francisco, and we have there's a lot of hills and beautiful redwoods. Some homes are built in canyons with redwood, so there's a lot of dampness. We also have homes that are built on bedrock and Tiburon, and water just flows down the hill when it rains and doesn't really seep in. So things like basements are red flags. Anything that's subterranean, hillside, HVACs get affected by mold growth. And then, every time you turn on the HVAC, it can disseminate these mycotoxins. To your earlier point, they are microscopic. Mycotoxins are about the size of a virus. I mean, they're extremely microscopic, and they waft around the house. People will say, "Oh, we found mold in my daughter's closet." And so we're fixing that. And I once heard an analogy about mold spreading throughout the house, sort of like if someone was, cooking in the kitchen and they were, cooking bacon, for example, and you can smell it down the hallway. Mycotoxins are doing that. They're not isolated to that one room. The building, I mean, we could have a 6-hour podcast about the whole building issue, because it really is one of the greatest obstacles to helping people get better. I'm in the San Francisco Bay Area, and we have 8 million people here, and there's really one or two inspectors that I trust to inspect the home properly. I mean, it's a whole art and science. Same thing with remediation. I would say, a majority of the time when people remediate, it's done improperly. We often say mold needs to be removed, not killed. So occasionally I'll talk to someone and they'll say, "Oh, they just came in and they painted over with this paint that kills off mold, or they sprayed some eco-friendly antiseptic cleanser," and you don't ever want to do that. In fact, when you disrupt mold, it gets angry and it releases more mycotoxins. So mold, like a skin cancer, should always be removed with clean margins. And, I often say there's 1,000 ways to do it wrong and very few ways to do it right. So diagnosing the human is one thing. They come in, I get the thorough history, it may come up or not.
Tests that you feel you can rely on, good tests.
Yeah, for sure. And I've used a variety of them over the years. I've cycled through, in the last decade, I've used a whole variety of testing. And right now I've locked in on using urine mycotoxin testing with a lab out of Texas is my preferred lab.
What's it called?
Can I say that?
Sure.
Real-time labs in Texas. And it's actually the first lab I ever used 10 years ago. And then as far as, Dana, everything's the details are everything, right? With testing, and same thing with Lyme testing, treatments is the same way. And so what we do is, I have patients, we provoke it with glutathione, because mycotoxins need to be mobilized to capture in the urine so that we get an accurate sample. So we typically give patients an IV of glutathione the day before they collect, but a lot of people don't have access to IVs. They can use oral glutathione for 5 days beforehand.
Oh, that's great to know. That's a helpful tip, actually.
Yeah.
Yeah, it's very complicated and it's extremely expensive. The problem with all of these things is that because they're outside, and purposely so, insurance companies don't want to pay for mold remediation, because they found out in the late 90s, early 2000s, how incredibly expensive it can be.
Yes.
And the liability can be tens of millions of dollars. As you and I have discussed, there are a couple of these famous cases where whole family was poisoned. The whole house, these multi-million-dollar homes are just absolutely infested. I spoke with someone yesterday who just fled their gorgeous LA mansion, basically in the middle of the night, and had nowhere to go. You leave their things behind because they feel ill when they're around them. And it sounds so, to me, the first time I heard these kinds of stories, I was very skeptical.
Yeah.
Really? Like, you can't take your sofa? What if you just get it
Right.
cleaned? Actually, it turns out they were right. It really is. And when you think about, like, at some point, I was talking to a doctor about it, and we were talking about the comparison to, like, permethrin, right? You can pre-impregnate your clothes, and then you can wash them like 20 times to 80 times, and you still have the permethrin in. It's hard to imagine that that's possible, and yet it is. And so I kind of now think of mycotoxins as being hard to get rid of like that sometimes, and people become extremely sensitive.
Yeah, that's when, especially when the patients are extremely sensitive to everything around them, they almost have to leave all their belongings behind. Furniture, anything porous that really absorb, mattresses, for example, I often say are like sponges for mold. And so when people, if they identify mold in their current location, they move into another location that's clean. If they take their stuff with them, they've really contaminated their new environment. So it does become very challenging. It's extremely costly. So it creates a rift with family members because there may be people in the household that aren't sick. Yeah. And so husbands may not understand why their wife is so sick and sensitive. I often say that, when I, diagnose someone with mold illness, it's a real, I feel like it's a real benefit to everyone in the household, and it's a real, I'm just glad that it extends the benefit to everyone else that's living there because they may or may not know. I mean, I am going through one of my patients currently is, she has an autoimmune condition, a scleroderma type condition. And, her husband's fine. Although when, in hindsight, when he got sick with COVID, during COVID, and he's a former collegiate athlete. So he's very fit. He's in his early 50s. And he had a cardiovascular event. I don't know if it was a stroke or a heart attack, but he became very, very sick with his COVID illness. Well, when I met her, she already knew there was a past history of mold in the house and is remediated, so she didn't even bring it up. And then on testing, she had really high levels. And, she's, it's very ironic. She's being treated at UCSF by a rheumatologist for this condition. And the medication he has her on is called Cellcept. And if you know anything about Cellcept, it's an immunosuppressive drug that's used in organ transplants and to prevent rejection. And Cellcept is derived from one of the mycotoxins. So it comes from mycophenolic acid. And I think that just demonstrates how immunosuppressive these mycotoxins are, right? If a drug company's putting it in a pill and selling it to suppress the immune response, clearly these mycotoxins are just, extremely immunosuppressive.
That's fascinating. I didn't know that. Now, is she able to tolerate the drug, or is it impossible now that there's this mycotoxin?
Right. Yeah. Well, because it does suppress inflammation, ironically, she hasn't felt any better on the medication. And as I shared with her, but her disease was progressing. And so she had took it for 30 days, no response, stopped it on her own, but her disease progressed. So she's sort of hedging her treatment right now. She's on it while we're also addressing the underlying issue. And as I shared with her, you could stay on this medication, but the mold is still going to be in your system.
Yeah.
She still has that in her body. And she had her house retested. Often what doesn't happen is after a home is remediated. And in her case, it was remediated years ago before I knew her. But people don't retest after. It's sort of like treating a condition. If someone has Lyme, you diagnose it and you treat them for a period of time, you always want to follow up testing. And so the house just got retested, and sure enough, there's, the remediation wasn't done properly.
Oh.
It could be a rabbit hole. It could be very costly for people. Unfortunately, I see people that are renters, and of course, landlords don't want to take on remediation or do much about it. Yeah, and people's, at times people's hands are tied and they get stuck in situations that are difficult to get out of. And that, I think, is one of the hardest parts about mold illness. It involves an outside building that, is different than just treating the person that's sitting, with you in your office. You have to take into consideration their environment. And I think, a lot of times in conventional medicine, we don't think beyond the room that we're sitting in with a patient, right? We have to ask about the environment. We have to look at more than just the symptoms the person's presenting with in the office.
So as like a general, in general sense, like what are a couple things people should know? You find out, say you take a test and you find out that you have been exposed to a high level of mycotoxins, mold. Where do you start? If you can do a couple of things on your own.
Yeah.
Some doctors say the most important thing is to get out of the environment. Is that true in your opinion, or?
Yeah. And I think, we were talking kind of what you were talking about earlier with a multi-million-dollar mansion and people having to flee. There can be different, say severity of water damage. You could almost think of it like an infection. There's a certain load or burden that comes into play, and that contributes to the severity of it. Right, on low levels, pathogens may not cause an infection. An infection is really when it establishes itself and causes issues. And so with mold and water damage, I think that if someone, if they're in a severely damaged environment, they do need to get out. If it is low level and maybe remediated, then, I think that's best case scenario. People love where they live. And it's almost heartbreaking to hear that you might have to move, or how do you tell your loved ones that this is what you're doing? So, clearly reducing exposure is always step number one. People can, when they're in their environment, they can also, use air purifiers. They can open windows more frequently, and we call it cross ventilation or air exchange is important. We can do that in California for, a good 10 months out of the year, maybe less, but you can't do that everywhere. But ultimately, reducing your exposure. People then often use things like binders. Binders are taken orally, things like charcoal and clay and humic and fulvic acids. And these mycotoxins are excreted in the bile. And so with a binder in the intestine, it binds up the mycotoxins and pulls it out of the body. We use a lot of glutathione to treat mold illness as well, because that facilitates clearance. I just presented a few months ago at a conference on the pathophysiology of mold illness. And as I was preparing that presentation, I went down, I kind of dove into all the research and looked at the mechanism of injury of mold or mycotoxins. And when you kind of had an aha moment halfway through all this literature, and I thought, okay, so if I'm just, when you look at some of the, I call it collateral damage that occurs. We have things like oxidative damage is probably the main mechanism of injury. Yeah. And that can affect things like mitochondrial function and cell membrane health and organ systems. And we also know mycotoxins trigger a lot of immune system dysfunction. There's really great studies out there on cytokines that are elevated. I think we once posted in my social media a side-by-side of cytokines triggered by Lyme and cytokines triggered by mold, and they're almost identical. And so there's a lot of immune system dysregulation, which is where these symptoms come from. And so as I'm reviewing this literature, I think, okay, if I'm just pulling the mold out, but there's this oxidative damage has occurred, we know blood-brain barrier can break down, mitochondrial dysfunction occurs, there's increased risk of neurodegenerative conditions like MS and Parkinson's, then it's also my responsibility to help my patients heal from that. So I kind of a light bulb went off, and I realized it wasn't just detoxification. There's also a healing piece that needs to come into play.
Are there things you can recommend for people who are just beginning this journey to talk to their doctors about in terms of mitochondrial? We're hearing a lot about mitochondrial dysfunction in the face of COVID. It's become something that is sort of in the mainstream, because people are getting, very severe ME/CFS-like symptoms from long COVID. You and I, again, talked about this before privately, just the the number of athletes, the number of really healthy, so-called healthy young people that are just being struck down by this. And there's a lot of talk about this being related to obviously persistent infection. We know there are 300 to 400 studies now on long COVID. You and I talked about the review recently in Nature that Amy Prohl and her team and Rudy Tanzi at Harvard, they all came together and put this review out recently. So there's persistence, there's potentially mitochondrial dysfunction. Where do you even begin? And what can you do for these things? What can you do for mitochondria, I guess, is one thing.
It's definitely it's a process for sure. There's people will take oral supplements for mitochondria, things like NAD. I think it's also mitochondria has a structure and not just a function. And so more recently, we've been sending blood to a lab in Germany that assesses mitochondrial function, kind of cell membrane health and mitochondrial membrane health. And that's been helpful to help guide patients in their treatment. We use a lot of IV therapy in my practice just because I find it works. It's what's most effective. I see really sick patients. And so, oral supplementation can get you so far, but we typically do complex IV protocols that really include a lot of phospholipids like phosphatidylcholine that help repair cell membrane damage. So phosphatidylcholine and another phospholipid called phosphatidylethylalamine are the two main phospholipids in the mitochondrial membrane. So that's part of the repair process that needs to occur. And phosphatidylcholine also helps detoxify and clear out these mycotoxins. You're essentially displacing the mycotoxins that have embedded in cell membranes and helping remove. So that's become a real big part of my practice, not just for mold patients, but for any chronically ill patient that this damage occurs. The other day I'm a cyclist and I was out on a ride and it came to me that when I look at these results, I go, wow, in a younger person, someone in their 20s or 30s, we're seeing mitochondrial and cell membrane damage that you would, typically see with age, right? And you've heard, when people are older and they get diagnosed with a condition and they'll say, well, the neighbor down the road, he got Parkinson's, but he is 76. And so it's bound to happen, right? It's accepted to happen later in life, or cancer or, fill in the blank. Really, it kind of dawned on me that chronic illness is almost advanced aging, right? So these pathogens or, toxins that we're exposed to or people are exposed to, they cause this damage that really speeds up the aging process. And that's why a 30-year-old can be completely, bedbound with fatigue from the collateral damage from an infection or toxin. In my practice, I feel it comes down to those two things. If you keep asking why, and you and I, there's all these other, associated conditions, whether it's mast cell activation syndrome or, these sort of peripheral conditions, they're really a result of. And if you keep asking why, eventually you either get down, in my practice, at least to, an infection or a toxin or both.
Right. I'm so glad
and then there's,
diagnoses in and out unto themselves. And everything has a cause, as you just pointed out. And that's the thing that I think is so important for people to understand. If you can get to the root cause, oftentimes there are better answers than just treating symptoms. I mean, I'm living proof, and I know you have many, many patients who are as well, whether that be Lyme, mold. And I think that we'll probably agree that these things all work together to sort of torture you. Amy Prohl, one time I called her like last year and I was having some really weird symptoms. I'm like, I wonder if it's my Lyme flaring, or I just wonder if I'm dying. She goes, yeah, so these infections like live to torture you for your entire life. So don't think you're dying. Like, this is just what they do. They just rise, they go back down, you treat them, you knock them down. This is just the nature of the beast.
Yeah.
And it can be super torturous. It can be really hard, but I do think they probably synergize in a very malicious way. Gang up on you.
Yeah. Well, I often say it is that perfect storm, right? And the analogy I once heard, it's like having I describe it as having tacks in your foot, right? If someone walks in the door with the myriad of symptoms and they have 6 tacks in their foot, and you find one, you find that they have Lyme. Well, they still have 5 tacks in their foot, and you need to address all of them for them to recover. And when you asked me to come onto the podcast, I thought, well, what can I offer? I want to make sure that the listeners, there's something that I could share that people could benefit from. And I think about the strategy and the approach in treatment a lot, and I think that you could have multiple insults at the same time, but there's a hierarchy in which you treat, and everyone is different. You'll see this a lot in social media where someone will say, well, this therapy cured my Lyme, and so everyone else should try this therapy because it worked for me. But ultimately, everyone is very different, and I think about this with especially with these chronic Lyme clinics that we're now seeing, and the research money that's going into advanced chronic Lyme. Ultimately, the studies are going to have to be very personalized and tailored. I don't know if we could say a patient walks in the door, and that's a challenge with the scientific method, is we typically want to isolate variables, right? We want to study just Lyme. Well, you and I both know that ticks don't carry just Lyme. In fact, the rule is they carry multiple infections, and it's rare that someone gets just Lyme. So if someone was tested by their pediatrician or their PCP and they had Lyme and they got doxycycline, well, it's a high likelihood that they have a co-infection as well. And those require different antibiotics or treatments. So it is complex. And I think the strategy is more, we're always looking for the treatment, the magic wand that's going to make it all go away. But it really begins with a thorough assessment. Yeah. And then the treatment strategy is what I think, even supersedes what the magic treatment that we're looking for down the road.
One thing that I think would be great to dispel is this myth that there is no Lyme and there's no tick-borne diseases. There are no tick-borne diseases in California. I can't tell you how many times I continue to hear from doctors and from patients. Yeah. Chris Christopherson didn't get diagnosed for 30 years because he lived in Malibu. Yeah. By the way, people travel, but there's Lyme in Malibu anywhere, right. So his doctors were just incredulous. And I think when I interviewed his wife, Lisa, about his, he famously had been diagnosed with Alzheimer's. And then he went to an integrative doctor who tested him for Lyme. He had it, he began treating, and within a month, after very serious decline, he had gone off the road, he couldn't sing and perform anymore. His wife said they were driving in the car, and this was on the cover of Rolling Stone, and she said the son of a bitch is back. The light was back, he was back to being himself to some degree, and he was able to go back on the road and recover to some, I don't want to portray it that he had this miraculous 100% recovery, because he didn't, but he improved a lot when he treated. Yeah. And but part of the problem was that his doctors all thought that because he was living in California for so long and Hawaii, he couldn't have Lyme. So they never even considered it.
Yeah. And his profession was to tour.
Yeah. His profession was to tour. But isn't it so common? You're in Marin County, right?
Yeah. Yeah. I mean, I have a lot of thoughts around this, and a couple of them come to mind. I mean, I just saw a study come out this week. I think from the CDC group of people. It was the epidemiology of 5 tick-borne infections in the United States. And you look at the maps, and they're always a little dated. But when you do look at a map of the states, clearly there's a major hot spot in the Northeast, but the maps also include most of the West Coast, right? And I know here in California, I think there's 54 counties. Lyme, and this is old stuff. These are, data from probably 10 years ago, but Lyme has been found in ticks in 52 out of the 54 counties. So we know it's here. And I always share what Dr. Bob Lane from UC Berkeley was doing in the 70s. He was studying ticks, back at the same time that, Pauli Murray discovered, or the children had the outbreak in Lyme, Connecticut, he was studying ticks here in the coastal range of Northern California and finding pathogens in ticks, Ehrlichia, Anaplasma. And so Lyme's been on the West Coast as long as it's, been in the Northeast. This isn't a new phenomenon. We just only recognized it in the mid 70s. We have a couple counties here. I think Mendocino County might have the highest incidence of infected ticks, and then we have Sonoma County, and then Marin County is number 3. Marin County happens to be a very active community. 80% of our county is preserved open space, so there's a lot of hikers and bikers and equestrian riders, and so people are out and about. And then, of course, a couple of years ago, there was the study about ticks being found on California beaches that were infected. So, it's a real disservice when physicians don't keep up with the literature. And of course, you can't expect people to keep up with everything. We're inundated with it. But back to the, point I mentioned earlier about being curious and open-minded, as more younger physicians come up, and occasionally, physicians train on the East Coast. And so they did their residencies or fellowships on the East Coast. And so occasionally a patient will share that they went to the ER and the doctor was familiar with Lyme and gave them a proper course of doxycycline. But it ultimately, medicine is too vast to be dogmatic. You have to be open, and change, takes time, but just being open to the evidence that's out there is the first step.
Yeah, it is. It's surprisingly uncommon that doctors will even take these things into consideration when you tell them. And that's the thing that's been so surprising for me as having dealt with chronic illness. I never expected not to be believed. I'm so not somebody that goes in making up stories. So I was like, of course, they'll just take me at my word. Wrong. Yeah. Absolutely not. When you come in with all these weird disparate symptoms, you get put in a psych bucket, or you get put in the anxious, high strung woman, hysterical bucket. It's just very strange to be treated like that when you're like, why would I make this up? Who would make this stuff up? But we know that these infections and even these mycotoxins and metals and stuff can cause neuropsych stuff. But what is the role of trauma, separate from all these infections? Is there a role that trauma is playing in chronic illness, and does it help to treat it?
Yeah, I think that a lot of, the trauma can come from a number of come from different areas, right? And I see. It's not uncommon for me to see a new patient, and on our intake form, I would say at least 50% of my patients will report some past history of trauma in their intake form. So they can write it down, and whether or not, I'll ask them about it, and they may or may not want to get into too much detail, but for a lot of my chronically ill patients, there is a past history of whether it's, psychological, physical, or sexual abuse. And, there's been a number of studies now from the big ACE study, which was the Adverse Childhood Experience study. And knowing that the what we call the limbic system gets damaged in we basically developed neuronal pathways that help our survival. And it served us at, one point in time. If you needed to run from the saber-toothed tiger, you're proficient at that. That's
describe what the limbic system is a little bit, just so people kind of understand the importance of addressing this.
Yeah, it's the alarm center in the brain, right? So it's what goes off when the body senses there's a threat. And it could be anything, right? It's that creepy sensation that someone might get being around someone. It's an alarm center, and it keeps us. It's a survival mechanism.
Yeah.
But people, later in life can also develop trauma from what you just described, from being sick and gaslighting. And I've also, my observation is that patients can develop trauma from not really being able to trust their own body.
Yeah.
You've heard this before, where people say, I don't make, I don't schedule lunches with my friends. I can't plan to go on a hike on a Saturday because I don't know what I'm going to get when I wake up in the morning.
Yes.
And so when you can't trust your own body, then there's a level of anxiety and uncertainty. And so the trauma can take many shapes and forms, but I do believe, we know this with like mast cell activation syndrome, for example, that stress can elicit a mast cell type of response. So it keeps the body in a sympathetic dominant state. And if we're never coming down from that, we're supposed to have these short bursts of stress, and not chronic stress, not waking up at 7 a.m. and getting in a car and commuting for an hour or whatever it looks like, work that's stressful. We're supposed to have short bursts of stress, and our modern society, unfortunately doesn't support that very well. So we have to be very proactive in taking care of ourselves, and stress management, meditation, walk in nature, whatever it is that works for you. But I over time, those neuronal pathways get so reinforced that people automatically go to that. And you can, there's limbic retraining programs where people can heal that limbic injury is the term that's used.
Yeah, that's interesting. So what do people, I have some friends that have done DNRS. I haven't tried those kinds of things, but I'm curious, is that a good program to try if this is one of the issues that's plaguing you? Or are there other programs or other things people can do to sort of settle their nervous system, their limbic system, the fight or flight response?
Yeah, absolutely. DNRS is one of them. Annie Hopper created that, and there's the Gupta program created by Ashok Gupta. Those are both online sort of programs that people can do from their own homes. EMDR is an old technique that's used with therapists, and that's a form of limbic retraining. Neurofeedback and brain mapping are also very effective. Some patients are using ketamine now too. Ketamine can also help with the neuroplasticity and help to retrain the brain. So there's a lot of tools out there. It's a matter of finding one that works for you and one that's going to be effective. But I do think for some people, like as I mentioned earlier, every chronically ill person has their own makeup, their own fabric, and what percentage of the pie is trauma and what is infection and what is toxin. Everyone's different. For some people, the past trauma plays a bigger role, or it keeps them stuck in a sick cycle. And that's the hard part. I mean, something we haven't talked about that I think is worth mentioning is this concept of, I've had these conversations with other Lyme colleagues where you could, if it is a kind of a clear-cut chronic tick-borne infection case, and you could put people on antibiotics and you cycle through various antibiotics over time. And of course, we try to support other aspects of their healing, detoxification, immune system regulation. And people can get to a certain point, right? They might get 60, 70% better, but they maybe never fully get back to their prior health. And that was always I think for clinicians, it was this conundrum. Like, why could we not get people, if a bug caused it and we killed the bug, why didn't their health or their energy get back to normal, or their pain fully reduced? But some people are fine with, they're just pleased that they're 70% better. And, if they were hardly functioning prior to getting diagnosed. But there's this healing aspect I've really begun to explore recently, and part of it has to do with the testing that I send to the German lab, and then the treatment that we use. But there's a healing, a cell membrane or cellular health that needs to occur. I always say it's, our cells are what make up tissues, our tissues are what make up organs, and our organs, of course, make up our whole body. And so if oxidative damage is one of the main mechanisms of injury, how we need to repair that damage, because you're only going to be as healthy as the health of your cells. You cannot have a healthy organ that's made up of unhealthy cells, whether it's the heart or the brain or the muscles, the joints. I think that healing piece of the puzzle has been missed for so long. And there's a mitochondrial researcher named Bob Naviau, who's down at UC San Diego. And Dr. Naviau's kind of been in the chronic fatigue, ME/CFS, and autism world for like 3 decades. He's been doing research. And recently he wrote a paper describing how we need to change our approach to healing or recover from chronic illness, that it's no longer, the old model was what we call a pathogenesis or pathological model, where this was the cause and we treat that and we move on. But with chronic illness, it's very different. I heard him speak at a conference in 2019, and I went and dug up my notes from that conference, and he had said the path from chronic illness back to health is not the same path that caused the chronic illness in the first place.
Huh.
And at the time, I thought, I wrote it down. It resonated with me, so I took a note of that. But at the time, it was like, well, what do you do with that, right? Clinically, there's always this gap. There's research, there's what we call bench medicine, and then there's the clinician that shows up and maybe has limited time with their patients. How do we test for that? How do we treat that? And so that's always been kind of a missing piece of the puzzle, but I think we're getting better at it now. I know that the tools that we're using in my practice and what I'm seeing on follow-up testing, and then what we're hearing back from patients, is we are helping them get closer and closer to that, to complete healing.
Yeah.
And to me, that's the most rewarding part. It's not just getting them out of that acute state and their symptoms. It's how do we also help them, prevent disease in the future. There's no shortage of information and in medicine. And if you're interested and curious and you keep looking and digging, it's very humbling, actually. Yeah.
What do you think about food? What should people be eating? Is food playing a big role in people's health?
Yeah, I mean, clearly food is our fuel, and it's as Hippocrates said, it's our medicine as well. And if we, putting the right fuel in your body is, pays dividends. Is there one perfect diet? I don't think so. I think everyone's a little bit different. There's a lot of dogma out there around diet, and I often joke, I rarely talk about diet with my patients, because the people I see are been chronically ill, and they're so sick that when they walk in the door, they don't say, yeah, I'm sick and I'm also eating McDonald's every day.
Right. I came in with a Whopper in my bag. Right.
Yeah. They're eating a really clean diet. They're, I think a really good general diet is what we might call an anti-inflammatory type of diet. So it's avoiding foods that are common inflammatory foods, like, gluten and dairy and sugar. And for some people, if they have a mast cell presentation, they might benefit from eating a low histamine diet. If, there's the autoimmune protocol diet, and there's a lot of various diets out there, but I think a plant-centric diet is really important, very hypoallergenic, high dense nutrients. And, there's a number of ways to do it, but clean food is where it's at. I think so much of our food supply is, of course, sprayed and contaminated. You don't want to be adding to your burden already.
Yeah, I agree.
Yeah.
We had, I've been madly tweeting about this for 24 hours because, back in New York now, and I did not know that New York City was now spraying pesticides from the back of a truck all throughout our residential neighborhoods in the city and in Brooklyn and in Queens. So I only found out about it because some guy from Manhattan took a video of it. He's sitting in his living room, 10:30, windows open. You and I know how these things aerosolize, and they go, again, like mycotoxins, they go way further in your little block. And then in the street, they're going into your apartment.
Yeah.
They're adhering to your furniture. They're, again, talk about these pyrethroids. They stay in fabric for a long period of time, right? So this guy takes a video, and you hear the police are sort of, leading them, shouting with their megaphones, stay 100 yards back, get in your apartment, close the windows. We're spraying pesticides for West Nile virus.
Wow.
There's been about 8 cases. Okay. So we're doing nothing for COVID. We're doing nothing to mitigate tick-borne diseases. But all of a sudden, West Nile, 8 cases, the entire city is sprayed with neurotoxic chemicals. And it just feels like it's so hard to avoid. We have no choice. Like, I don't want this. I called the Department of Health multiple times yesterday to find out, what exactly are you spraying? Are you going down my block, or are you just mostly centering on the parks? Turns out, they were going down my block between 2 and 4 a.m. I have a dog that had a very severe seizure from pesticide, herbicide. I told you about death. So and she's severely averse to pyrethroids. And that's what they were spraying. And I was like, well, a little warning, like, some guy on Twitter shouldn't be the one telling me it's on our website. Okay, well, I'm not like in the habit of going to your website to see what kind of horrible things you're doing this week. And also, like, I have a little herb garden, so now my herbs, I feel I'm trying to minimize, I do what I can. It's expensive to be healthy. It's expensive to buy organic foods, but I know that it's important. So, like, I do what I can, and I'm like, this happens. I don't win.
Yeah. These are things that we, well, first of all, I thought we stopped doing that in the 70s, maybe early 80s, when they would spray. DDT's been banned, I want to say, since the late 70s in the US. But, I've heard stories from patients over the years, and you've seen the famous photos of trucks, and hot summer night in Texas, and they're spraying DDT out the back, and kids are running behind it because it's hot and the the spray is cool.
God, I saw those pictures yesterday. People were posting them back to me, complaining in New York, saying this is what I grew up in. And we used to chase the trucks because it was fun to run through the cloud. Right.
And that's those are what we call persistent toxicants. And so you can find those in people's body 40 years later. The half-life is something like it's amazing. So I didn't realize public health was that was even allowed at this point. But these are, there's something like 80,000 chemicals in daily use in the United States, and something like 200 of them have been tested on humans. So we don't know what the other 79,800 do to humans, human exposure. I think, again, as we zoom out and we think about the patients listening to this, and the chronically, ill folks out there, and maybe physicians and scientists that are also listening, and how do we help people advance? How do we get them better? What can we do to help them? And this is one of those areas that I think is grossly under-recognized. That I hear occasionally, I'll hear a physician that's been practicing for 30 years and say something like, the patients I see now are much sicker than they were 15, 20 years ago. Why is that? Is it a rise in tick-borne infections, or mold illness, or environmental toxicants as well? So it's this perfect storm. And to see people in their kids in their teens, or people in their early 20s with chronic fatigue syndrome and other neurological conditions, it's just I think our environment is having a major impact on our health, and it's really hard to get away from, right? I mean, if you're inland, or if your public health department, is spraying right down your street, it's very, very difficult to get away from. You could buy organic all day long, and the air we breathe, it's very challenging.
It is. And I was doing some research last night about how long these particles, these pesticides and herbicides, stay aerosolized.
Yeah.
There's a Nature review, 3 to 10 days. I mean, it can probably be hours depending on the wind. And we know a lot more about, it's more in the public domain now about air quality. And, I got really interested in this during the COVID during the COVID pandemic
Yeah.
because COVID's airborne, and we have to figure out how to protect ourselves. We had to learn a lot of stuff about air. But yeah, I didn't know. You just, as you say, I'm curious too, like you are, and I just keep learning, and I just keep going down the rabbit hole.
Yeah.
And every time I go further, I'm like, oh, I don't want to know there's nothing I can do. There's so
Right.
little I can do. But I should say one thing that I think is important to say is that when I first got Lyme, and I'm so sick, before I could get to a doctor, because there was I had to wait a couple of weeks to get in.
Yeah.
Somebody put me in touch with their friend who had a really severe case of Lyme that she came back from. She told me, if you don't eat paleo, like starting today, don't call me for help, because you have to do something immediately to reduce inflammation. It was such good advice. I'm not saying everybody will benefit from paleo. I am saying I did. And I really realized the importance of diet in that moment, because I had a lot of physical pain, just aches and pains, fibromyalgia kind of stuff, joint pain.
Yeah.
I would say that by the time I got to the doctor a couple of weeks later, having done very strict paleo in that period of time, my pain was reduced by 70%. I had a lot of other symptoms, but still, I'll take it. I thought it was really incredible.
It's profound, the effect that diet can have on our health and inflammation in the body. And, sometimes we think about I call it total body burden. It's like a bucket, right? And our buckets, everyone has a different size bucket, and we might have a different spigot at the bottom. Some people eliminate well and others don't. And once your bucket is full, if you, sprinkle in a little, it could be anything. It could be gluten. It could be another pathogen. It just tips people over the edge. It could be perfumes, etc. And so eating that clean diet doesn't add to that burden that was already there. I mean, I think in general, when people are in a healthy state, they can eat a varied diet and not react to everything. Exactly. But I see some people that can hardly eat anything at all. And, whether that's mast cell activation or leaky gut, I see a lot of my patients when we test them, because I'm a proponent of testing and using objective evidence. A lot of people have gut inflammation, and treating that helps reduce their reactivity to things. I always say with something like leaky gut, it's not about the origin is in the gut, but the symptoms are systemic. So it is headaches and brain fog and aches and pains and fatigue. And so if you reduce the inflammation that you're putting into your diet or putting in your body, you're not going to, trigger an immune response.
Is there a good test for leaky gut?
There is, yeah. There's blood and stool testing for leaky gut. You typically.
What are the tests called?
Well, there's a lab called Cyrex that has CYREX that has a blood panel of leaky gut markers, and then there's stool tests that also include a marker called zonulin. And so, anytime we order a stool test on patients, we always include zonulin because, that's an important connection. I often see leaky gut associated with things like SIBO and even this mast cell activation syndrome. They can all kind of run in the same circle and be interrelated. And so healing the gut is a critical part. 80% of our immune system is on the other side of your gut. Home base to your immune system is right around your digestion. So digestive health has an influence on your immune health. And when we talk about inflammation, we're really talking about our immune system. Mm-hmm. And so, anything we can do to what we call modulate the immune system, improve, so it's balanced. We always say the immune system wants to be like Goldilocks' porridge. You don't want an overactive inflammatory immune system or a weakened suppressed immune system. You want a just right immune system.
Yeah. I mean, you just made me think of LDN. I think you might have been the first person to really talk to me about LDN. And it's been a hot topic lately because a lot of long COVID patients have stumbled upon it. This is something Lyme patients have been taking for a long time, and probably many, many others. Tell us a little bit about LDN, and have you had a lot of experience using it in your patients? What has it been like?
Yeah, I love LDN. I think it's probably one of the best tools in my toolbox. LDN stands for low dose naltrexone. Naltrexone is also manufactured as a drug in 50 milligrams for alcohol and drug addiction. And it's a medication that's been around since, I believe, the 60s. Yep. But in the early 80s, some doctors in New York started using low doses of it with AIDS patients to help keep them alive. And so they were using very low doses, or like a milligram or so. And in low doses, the naltrexone is what called a partial opiate antagonist. So it partially blocks opiate receptors, and then your body makes more endorphins, and so that helps to modulate the immune response. It reduces inflammation. It helps with, we even know with brain inflammation. I use it when there's gut inflammation as well. I mean, any autoimmune condition. I guess shouldn't give medical advice, but I think most autoimmune conditions would benefit from LDN.
I think so. I mean, I hear it all the time, honestly.
Yeah. Neurological conditions, MS, Parkinson's, all of those neurodegenerative conditions really, really benefit from LDN, and it has to be dosed right. I always start with a milligram. I used to start with 1.5, and then you basically increase the dose each week up to. It used to be up to 4.5. I now start patients on a milligram, have patients increase a milligram each week up to 4. And I've had better success with that. I think patients tolerate it better. One of the more common side effects is it can affect the ability to fall asleep. Mm-hmm. And so if that happens, because you typically take it at bedtime. So if that happens, I just have patients take it in the morning.
Dreams. People, have wild dreams on it. It's famously very vivid dreams.
Yeah.
Who had a 9/11 related smell and taste disorder. Tried many things, and LDN seems to be the best drug or the best therapy that he's landed on to help his smell and taste. And again, lots of emerging research in the advent of COVID with a lot of anosmia, but I haven't heard too many people talking about that, but I thought that was super interesting.
Yeah. It's a great medication. It's, for all the conditions we've discussed today, there's an application of LDN there. Yeah.
There's a great little book. I think it's actually called the Little LDN Handbook or something like that. People could read. I read it and I thought it was really, really interesting, quick, easy read. And it just gave me a really good overview of the things people are using it for cancer and all kinds of other stuff. No, it's interesting, and it's really, really safe and easy to tolerate for most people. So that's another.
It has very few side effects. It's a safe. It has a long track history of being an effective, safe medication. I wrote an article on my website about LDN, the use of LDN for Lyme disease, chronic Lyme, and I put a lot of the research in there around how it would benefit people with Lyme. So. That's it. It's an amazing medication, and of course, it has to be compounded because it's used in low doses. Some people try to get a 50 milligram tablet and then make their own dose, and I don't recommend that. I think you really want it compounded in a precise dose, and that's where you're going to get the most benefit.
That makes sense. Absolutely. So before we go, since we're on the topic of LDN and long COVID, are you seeing long COVID in your practice now with complex chronic illness? How is it impacting people? And are there some strategies that you've landed on that have been helpful? I mean, it's interesting to go to somebody like you because you know a lot about chronic infections already, and most doctors are completely at a loss when it comes to chronic infections driving chronic illness. So I would think you would be a natural sort of go-to person for long COVID issues.
I think any physician that was treating chronic infections like Lyme disease or chronic viral infections was pretty well positioned to treat long COVID. But as we've all realized that it's a very challenging condition. There's still a lot that we don't know about it. There's been theories since 3 to 6 months into COVID. We were theorizing why some people had persistent symptoms, from autoimmune to cytokine storm to triggering mast cell to viral reactivation. I mean, there's just been a number of theories out there, and I often say I've yet to meet a long COVID patient that didn't have something else going on. Sort of that tack in the foot analogy I used earlier. And whether they knew it or not, that's the thing, is people say he was perfectly healthy until he got, and that may be the case. There may be those patients out there. The folks that I've seen when we run, I will tend to cast a broad net with tests and figure out what else is contributing to that total burden. And when we run other tests, they may have, other infections, or they may have, high mycotoxin levels that are suppressing it's like that perfect storm that happens. We know this virus can persist in people's bodies now. And so that may factor in as well. It's really, clearly no one's cracked the code. If we had, then there wouldn't be, however many million of people walking around right now with long COVID. I've also been using, I've been looking at that cellular damage that can occur from any chronic exposure, and then applying the treatment that we use to help repair that. Because there's, again, to Dr. Naviau's point, that the road from chronic illness back to health is not the same path that caused it. So if it is viral persistence and we just put someone on an antiviral, for example, are they going to fully recover?
Are you finding benefit with using antivirals? We know, like, as you mentioned, COVID can activate
EBV,
latent infections like EBV, also Lyme. We're seeing it a lot in the vector-borne diseases. They're reactivating people that were in remission or recovered, come back in, and they have the same symptoms again after they got COVID. So what can you do about that?
Well, 90% of people, 9 out of 10 people walking around have elevated IgG antibodies to Epstein-Barr, because 9 out of 10 of us have been exposed in childhood. And so what is reactivation? Is it just a high IgG titer, or, if you see an IgM Epstein-Barr viral titer, that's treat. You want to treat that for sure. Yeah. I use T cell testing in my practice for these chronic viruses. And T cells will only be elevated with an active infection. So if I have, an EBV positive T cell test, then I'm absolutely treating that. But to your question around reactivation of things, or are we using antivirals? Yeah, for sure. And really, it really ends up being that sort of perfect storm, and you have to assess everyone individually and figure out what their makeup is. What do they need? And what's the hierarchy, the strategy in getting them better? What is it going to look like going forward? I don't know. I guess the future will tell. But right now, using everything, all the tools that we use with other chronic illnesses, I think is really the most effective way to help people. I have a patient right now who I treated years ago for Lyme and Bartonella, and she'd recovered and, was living a fairly normal life. And then she got COVID, we think one of the earlier cases of COVID. And she has been so sick since that happened. I mean, when I see her, she'll say chronic Lyme was nothing compared to what I'm going through now. And she kind of has an autoimmune encephalitis picture. And so she has a lot of brain inflammation, and we're trying to use a therapy called IVIG for her. And it's messy out there, but I'm optimistic that, a lot of the tools that we've used historically are what really help, move people in the right direction.
I am seeing some people getting benefit on things like LDN, hyperbaric oxygen, things that tools that we've learned from the Lyme world. The patients in the Lyme world, they seem to be applicable to some degree with these other issues. Well, I can't thank you enough. This is, first of all, time has flown. We have to do a part 2. We still have a lot of ground to cover. I'm so happy that you came on. Did I miss anything? Is there anything that you wanted to cover before we left, or did we cover?
We covered a lot. I could talk. I love this. And first, thank you so much for having me. It's an honor, and I could talk about this stuff all day long. I really enjoy the work that we do. I'm, grateful for organizations like Bay Area Lyme and people like yourself that have, really, put out great information, or outspoken about these conditions. Because, us physicians are on the front line, and we don't get, we just I always say it's my obligation is to the person that's sitting across from me in my office is to help them get better. And, despite what, CDC guidelines are, or whatever else it may be, my job is to get the patient better. And so I appreciate all the work that groups like yourself and Bay Area Lyme and LymeDisease.org, there's wonderful groups out there. So thank you for all the great work that you do.
Thank you so much for saying that. Where can people find you, and where can people learn more about you and read your great articles that you publish?
Well, my website is Dr. Todd Maderis, and just Google it and it'll pop up. I haven't written much lately on that site, but we do post a lot of research on my Instagram account, which is Dr. Todd Maderis. And also I'm on Twitter, and I think that's Dr._Todd.
Okay.
Yeah.
Great. Well, we will continue our conversation. Thank you so much for this. This has been
welcome.
Awesome and wonderful. And you're going to help a lot of people. Thank you.
Thank you. Thank you for having me. Great to see you.
Thank you for joining us for this episode of Ticktective, a program of the Bay Area Lyme Foundation. For more information or to get involved, please visit us at bayarealyme.org.